Good afternoon. Welcome to this Penn LDI virtual seminar, where we're focused today on the topic of reforming Medicare Advantage to deliver on its promise. We're excited to host and have this conversation today with 4 experts on this topic. My name is David Grandy. I'm the Director of Policy at Penn's Leonard Davis Institute of Health Economics, and we'll be moderating this session today. So with that, without delay, I would love to go ahead and begin to introduce our panelists. So first, we have Tricia Newman, who is a Senior Vice President of Kaiser Family Foundation and Executive Director of its program on Medicare policy, and a widely cited Medicare policy expert on issues including the health and economic security of older adults, payment and delivery system reforms, and our topic today, of course, Medicare Advantage. Mark Miller leads Arnold Ventures' work to lower the costs and improve the value of healthcare. He was previously the executive director of the Medicare Payment Advisory Commission, or MedPAC, as I'm sure you all know it, and has also held key roles in several federal government agencies, including CBO, CMS, and OMB. Then we have Zuri Song. Zuri is an associate professor of healthcare policy and medicine at Harvard Medical School and a general internist at Massachusetts General Hospital. Dr. Song's research focuses on efforts to improve the value of healthcare spending, including studies of payment reform, pricing of medical services, financing of health insurance, and quality or appropriateness of care. And rounding out our panel is Richard Frank, the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School. He previously served as an Assistant Secretary for Planning and Evaluation in the U.S. Department of Health and Human Services. His research expertise includes long-term care financing policy, healthcare competition, and implementation of health reform. So I want to start with just a few framing comments, and then we will jump right into a discussion with our panelists today. I want to start by saying this year, Medicare Advantage surpassed a pretty remarkable threshold. The program now serves more than half of all Medicare beneficiaries. But we do see wide variation of Medicare Advantage enrollment across states, some states in the single digits, some as high as 60%. And then certainly across counties, we see very high Medicare Advantage penetration, mostly around large urban areas. Enrollment in the program is also highly concentrated among a relatively small number of managed care firms, and there are enrollment trends that vary by racial groups. Black, Asian, and Hispanic enrollees sign up at higher rates than white enrollees, but members of racial and ethnic minority groups also tend to be in plans with lower quality ratings. So as the program takes on this very large role in the delivery of healthcare to millions of Americans, there are a lot of questions about whether it's fulfilling its original goal of delivering quality care at lower costs compared to traditional fee-for-service Medicare. And so that's what brings us to this conversation today. And I want to start by asking Tricia if she could kick us off with an overview of the growth and evolution of Medicare Advantage over the last decade, looking at enrollment, but also disenrollment and what we should be examining there. And then if you could talk to us a little bit more in detail about 2 things that may be driving the record enrollment, the marketing that MA plans do, and also the supplemental benefits that they offer. So Tricia, why don't you get us started?
Sure. Thank you, David. And thank you for inviting me to be with everybody today. You're absolutely right that Medicare Advantage has come to dominate the Medicare program in terms of enrollment and in some ways spending. More than half of all people who are eligible for Medicare Advantage enrollment, meaning people with Part A and B, are now enrolled in a Medicare Advantage plan with significantly higher rates among Black, Hispanic, and Asian beneficiaries than among white beneficiaries who are still not at the 50% level. Enrollment has been steadily climbing over the past decade, more than doubling since 2010, when about 25% of people on Medicare were enrolled in a Medicare Advantage plan. That's kind of interesting because 2010 was the year of the ACA, of course, and that's when there was significant controversy over changes in payment that were projected, at least, to result in a significant decline in enrollment. But that actually didn't happen. Enrollment has escalated since then. This enrollment growth is due to a number of factors, but we certainly see enthusiastic insurer participation, which has fundamentally changed the architecture of Medicare. So today the program looks more and more like a marketplace of private plans than it used to when it was really a national program where there was a small role for Medicare, HMOs, and PPOs. And that looks very different for beneficiaries. For example, this year, the average beneficiary has a choice of more than 40 Medicare Advantage plans in their area. This creates opportunities for people because of the benefits that are offered and other features, but it also creates real challenges. I don't know if you all know folks who are turning 65 or on Medicare, but I get a ton of calls from people who cannot sort through the coverage options and find that they don't understand the trade-offs involved in traditional Medicare versus Medicare Advantage or among some of the Medicare Advantage plans. Dave, you asked me to talk about two things that are driving growth, and I'm happy to do that, but I have a much longer list, but I'm going to start with the things that you mentioned. One of the things is all the extra benefits. These are very appealing to people, and it separates Medicare Advantage from traditional Medicare. Most Medicare Advantage plans are offering some dental, vision, hearing benefits. They're also starting to offer more other benefits that are of interest to beneficiaries. We're seeing Instacart cards, debit cards for pharmacies and grocery stores, and people feel like they're getting something for nothing. And in fact, it is for nothing in some respects because they tend to not pay a supplemental premium for Medicare Advantage plans. Most people who are in Medicare Advantage plan pay their Part B premium, but not a separate premium. So that all sounds pretty good to people. And it distinguishes Medicare Advantage from traditional Medicare because people in traditional Medicare not only pay the Part B premium, but often pay a supplemental premium for extra coverage that they believe they deserve. Because for one thing, traditional Medicare does not have an out-of-pocket limit, which sets it apart from most health insurance plans these days. And it doesn't cover all the other bells and whistles, the other benefits that are covered to some extent by Medicare Advantage plans. So quite naturally, people are drawn to that. I don't know that people are really thinking about some of the things that may not be appealing when they looked at Medicare Advantage, like some of the network restrictions, but that's for another day, and that's sort of not what's drawing people in. I think one of the other factors is aggressive marketing. We did a study last year where we looked at plans that how plans were marketing on television, and we did a tracking project with the Wesleyan Media Project, and we looked to see what are these plans. And I have to say, I was surprised that the advertising was so dominated and focused on Medicare Advantage. We saw very few ads for Medicare drug plans or for Medicare supplements. It was really Medicare Advantage almost exclusively, 86% of all of the TV ads. And there was just a lot of them. So anybody who was watching TV would most likely be seeing multiple ads during the day for a Medicare Advantage plan. And there was a bit of a different emphasis or feeling to the broker ads than the ads sponsored by insurance companies. The broker ads, I don't want to say aggressive, but it felt a little bit more aggressive in driving people to call a 1-800 number, which seemed like Medicare, but it was a Medicare hotline. And then they were selling Medicare Advantage plans through that hotline. So there was some question, and at least in our minds, about whether people thought they were calling Medicare or were calling a broker. Brokers also, we've learned from studies that others have done that they tend to make more money in selling Medicare Advantage than traditional Medicare. And the Commonwealth Fund has actually done some interesting work there. And one of the most interesting findings I found was almost an aside. They looked at commissions and noted the commissions were higher for Medicare Advantage than Medigap. But one thing that struck me is when they asked brokers and agents what they would personally choose, brokers and agents said they would personally choose traditional Medicare with Medigap, believing that the combination offers better coverage and choices than Medicare Advantage, particularly as people age. That's almost a quote. which is, I found that interesting because, the financial incentives are really to sell Medicare Advantage rather than other products. I just need to mention just a few other motivations that might be getting people into traditional Medicare. It's simpler. It's one-stop shopping. They don't need Medigap or Part D. Employers are increasingly moving their retirees into Medicare Advantage and increasingly not giving their retirees a choice, so that if they want their retiree benefits, they can't really be in traditional Medicare with a retiree supplement funded by their employer or former union. More and more employers are saying, here's how we are offering retiree benefits. And now there are more than 5 million people with employer-sponsored plans in Medicare Advantage. So there's that passive enrollment. Lack of knowledge about traditional Medicare. That's also another factor. People just don't see ads for traditional Medicare, and they're seeing all this good stuff for Medicare Advantage. And then finally, I think there's just a lack of information generally that's out there that might make people raise questions about whether they should be in Medicare Advantage or traditional Medicare. And I think of provider networks as probably, and as one of the factors. Maybe another might be prior authorization and denials. So I think all of that is sort of interesting. I think you also asked about disenrollment. And disenrollment, disenrollment rates are, I don't know whether you call, less than 20% kind of low. I think that was a recent number put out by CMS, 17% voluntarily disenrolled from an MA plan in 2021. But I think the thing we want to keep in mind and look for is who is disenrolling and why they are disenrolling. And in that area, there's some evidence that people dually eligible for Medicare and Medicaid are disenrolling at somewhat higher rates, and people from communities of color. I think that's an area that's ripe for research.
Great, thanks, Tricia. I'm wondering if, just before we leave you for a moment, if what do we know, or what can we bring into this conversation about the dynamics, about disproportionate impacts on racial minorities and some of the racial inequities that arise in Medicare Advantage? As I mentioned in those opening remarks, we certainly find uneven patterns with respect to the quality ratings of plans. What is known about that phenomenon, and what can we say about it?
Yeah, there have been a few studies that have compared the experiences of people in Medicare Advantage versus traditional Medicare, for sure. And as you pointed out, there's I think an alarming study that was pointing to the quality ratings of plans that were enrolling Medicare beneficiaries from communities of color. But I think there's a lot we really don't know. And what we do know is that that people who are Black or Hispanic or from other racial or ethnic groups are enrolling in rapid numbers, in part, I think, because they feel a financial imperative to do so, because Medicare Advantage plans don't have a supplemental premium and do offer these extra benefits, or they may be passively enrolled because of they're also on Medicaid, they're Medicare beneficiaries on Medicaid. But it would be great to know more about their experiences in Medicare Advantage plans. For example, we don't know who's using these extra benefits and whether they're of value. We don't know very much about outcomes and how that varies by race and ethnicity. And I think, we don't know about prior authorization and denials and whether that differs among people based on race and ethnicity. So as more and more people of color are moving into Medicare Advantage plans, I think it's really, really important to collect better information so we understand how well these programs are really working for people, including those with the lowest incomes and the greatest needs.
Thanks, Tricia. Mark, I want to move to you next. Tricia, obviously, in her comments, I think if we take a step back, there's a broad question about the value proposition of Medicare Advantage, and we can think about that value proposition from two perspectives. There's the taxpayer, perspective, as we think about solvency of Medicare as a public program and whether government dollars are being invested in an efficient manner. And then we can think about the beneficiary issues in terms of whether these plans are, delivering value and quality to enrollees. So I'm wondering if you could talk to us a bit, maybe starting with this value proposition question for society and the public sector as we think about government investment, and then similarly from the beneficiary perspective.
Yeah, I can start on that. One thing I'm going to do though is just reframe a little bit what you said, and I completely agree with the division, and I will respect the division you've made in the question. With respect to the taxpayer, there are issues that I will get into momentarily about, and whether we're talking about MA, managed care, whether we're talking about fee for service, my motivation is always like, pay what you need to pay in order to assure that the beneficiary gets access to quality of care. There are many places in which, as a taxpayer, we're paying more than we should be, and I'm going to delineate that a little bit. And then your second half of your question was, and the value to the beneficiary. But I want to stay on the taxpayer side and just remind everybody, remember the beneficiary is also paying to support the program. And that's that's the big distinction I wanted to make in your question. If we're unnecessarily paying because there's upcoding on the risk scores, the beneficiary is also carrying that cost. And to the extent that it's happening on the MA side, or managed care side, all of the beneficiaries in the program are paying for it because it gets ground into the premium that they pay. So the taxpayer issue is also a beneficiary issue, and I try and pound away at that, and when talking to the Hill and that type of thing, because there's always this, we're trying to protect the plans, and it's like you're protecting the plans, but you're making the beneficiary and the taxpayer, bear the burden. The value, you can think about I think that the notion of the value of the insurance program to the elderly is self-evident in terms of, the care that they get, the protection of their income, that type of thing. And so, it's really trying to think about it two ways. There's the broad sustainability of the program. And I'm going to probably not speak about that a lot here in this answer unless you really want to get into it. But we're talking about, already federal deficits that are reaching the size of the debt that's reaching the size of the economy, and that this program needs to be thought about for its long run sustainability, how to restructure the fee for service benefit, the MA benefit, how we set the rates throughout that. And even if you do all of that, I believe there's going to be a need for additional revenues brought to bear. So that's kind of the big giant picture, and we could get into that. The more micro stuff, I don't think of this as micro, but the more intermediate stuff is what's going on in MA where this is not a value to the taxpayer or the beneficiary. There has been tremendous amount of upcoding in the program on the risk system. I think with some of the latest estimates out of MedPAC are north of $20 billion annual in upcode, which I don't see as a value to the taxpayer, to the patient, to anybody in particular. There's a recent round of research that's come along now that also suggests that there are selection effects that are being reflected here, which depending on how they play out relative to the coding may mean an additional amount of overpayment. The quality program, in my view, is an add-on payment. I think, again, this is much deeper than I have the time for. There's measurement issues and gaming issues in the quality measurement and payment process that I would completely reform if it were up to me. There's issues around disenrollment, which Tricia has touched on. The notion of, when people may move from plan to plan, but move out of the plan to fee for service. And there are questions why that happens, and also to your equity issue, who it happens to more often relative, white populations versus minority populations. And then, of course, Tricia has also implicated the marketing. And over on the patient side, one thing I would say about the supplemental benefit for everybody's, benefit, I think everybody knows this, but you have a benchmark and there's whole questions around the benchmark, which I think Zuri is going to get into, how that's set, how it could be set. But then if you bid below that, a portion of that goes into the supplemental benefit, which the beneficiary gets. And a couple of things I'd like to get across there, and I think Tricia has implicated certainly part of this. But remember, there's often a statement of like, oh, well, all of that's a benefit to the beneficiary. But remember, this is a fully loaded benefit. So probably something like 15 points of that go directly to the plan when I offer the benefit. So extra benefits also benefit the plan in terms of revenue. And then there's questions about whether the benefit that's offered is a truly valuable benefit, one that's used actually by beneficiaries, and to the extent it's poorly structured or purposely structured that way, that's just an additional benefit that could travel to the plan and not necessarily to the beneficiary. Now, having said that, I do think there's an important role for supplemental benefits that managed care plans can offer to beneficiaries. I would if it were up to me, I would probably be more rigorous about standardizing the benefit packages so that the beneficiary has a much clearer idea of what they're getting, and the bidding process, it's much clearer what the taxpayer and the beneficiary who pays for it are getting. I would probably standardize things more. And from my point of view, I think the beneficiaries, and Tricia implicated this point as well, often they may seek managed care plans for a few reasons, but one of those reasons is protecting themselves against out-of-pocket costs. And I think, probably the first and most important supplemental benefit, this is my opinion, is, either your premium protection or your out-of-pocket protections. And then you move into the benefits that other people mentioned, like dental and vision and those types of things. One last quick thing, and at this point I've forgotten the question entirely, but one last thing on the quality question and what people are getting out of this. There is a huge problem in measuring quality in general, but also comparatively between MA and fee-for-service because of the way that quality data is collected. And again, I could get deeper into that, but I think I'm only supposed to talk for 5 minutes and feel like I've been talking for about an hour and a half. So I'm going to stop here.
Well, we will certainly come back to you. I think you teased a lot of future questions that we might get into, but I want to move on to Zuri. As been alluded to in Mark's comments, there's a lot of issues when we think about the payment structure of MA. There's another phenomenon going on, which is vertical integration, where you have health plans now owning related business and a general corporatization of MA impacting, this idea of linking, insurance with delivery systems. And so as we think about this vertical integration, again, health plans owning other elements of our healthcare system, what are the implications for patients and providers, and how might we think about that in terms of cost implications as well?
Thank you, David. I'm grateful to the comments of Tricia and Mark, and look forward to hearing from Richard as well. At this point, we see quite diverging paths among providers. You're right that there are health systems that have become MA plans. There are health systems starting MA plans of their own. There are also primary care physician groups that have become MA plans or purchased the risk from the plans to manage the care of that population of patients, where the plan gets a cut off the top and the provider group keeps the remainder under the capitation. And there are also insurers that have increasingly acquired providers directly, insurers who have large books of business in MA. Just common examples that we hear about might include the United ownership of 70,000 doctors in America, as they report, or the CVS Aetna acquisition of Oak Street, which is a primary care group just this past year, and Signify Health the year before, which is a home health company, or the Amazon acquisition of One Medical recently, which is another primary care practice that previously acquired Iora. These are all examples of this type of consolidation or corporatization, so to speak, of primary care delivery, but also in general, this merging of both the insurance function and direct healthcare provision. At the same time this is happening, the diverging path in parallel is that we also have emerging news of health systems dropping MA plans, and indeed other health systems discouraging patients from enrolling in MA in the first place. So rather than embracing MA, there are many examples in California, Oregon, South Dakota, Oklahoma, Montana, Kentucky, Georgia, Ohio that I can think of, where hospitals have decided to walk away from MA and actively push patients or nudge patients to not enroll in MA plans. And this is largely due to the prior auths and denials that I think Tricia talked about. And so what distinguishes these two diverging paths? Well, one factor may be that the health systems that are ready to embrace MA, or the physician groups that are embracing MA, tend to have a primary care function where they have the attribution of the covered lives and where they get to keep the savings from the capitation, where they can also control largely the coding of diagnoses and the management of the care. Whereas hospital systems that have decided to shun MA are those that don't have a primary care base and rely on referrals, where denials and prior auths really matter for people's access to them. And so it's not yet clear whether these two diverging paths will, whether one will outlive the other. Neither path has been rigorously evaluated to date, and it's frankly too early to tell what the implications are for providers or patients on a large scale. But we have anecdotes of patient experiences and provider groups doing this in the market.
And so if I could just follow up on, we did get a couple of questions from some folks who I imagine are connected to hospitals and health systems in some fashion that point to this issue of frustration with prior auths, denials, and delays on payment. I guess what you're saying is like this exodus from MA is relatively recent, and we don't have a lot of data yet at this point to quantify that or understand the reasons, but there's a lot of anecdote that suggests that there's a lot of friction in the system for providers that has emerged.
Agreed. This is an early chapter to the story, but I would just note in a quick, maybe an effort to provide a pithy statement, that one person's denial is another person's savings under capitation.
Well said. All right, Richard, let's move over to you. A lot has been put on the table by our three other panelists, and I want to ask you, how you would respond to some of the issues that have been raised today, and highlight which among these issues or any additional issues that you want to put on the table are most important to tackle now, and how the federal government might go about doing it.
Great. Small question, and I'll try to do it justice. Let me start with something that both Tricia and Mark raised, which is the complexity of making choices in the MA program. And this shows up in several ways. One, it's well known among psychologists and among economists that when choices get very large, I think Tricia said 40 is the sort of average number of choices, people start to make mistakes. It's very hard to make comparisons. And that has led to a considerable body of evidence suggesting, one, that people make mistakes, and then people don't change once they've made that mistake. They are very reluctant to move away because there's, in a sense, a level of status quo once it's been established, or inertia, if you like. And so that kind of choice overload is problematic for having an efficient market, because that's, in a sense, what we're counting on is to have market forces really drive value and efficiency. The second thing is the narrative about the program, which is both a matter of policy and a matter of marketing, which is both Tricia and Mark talked about zero premium plans. Well, zero premium plans are not zero premiums. People have to pay the Part B premium. And because for most people, that's pulled straight out of their Social Security tax, it's not visible. And so people make errors in choice by believing that they're getting a zero premium plan when in fact they're continuing to pay Part B, and there are actually lower premium or lower cost options available to them that they forego because they think they're all the same. So that's a second point, and I think that Mark started to point to some fixes. Certainly standardizing benefits is a helpful first step in terms of trying to let people make comparisons, on a sort of more easily computable basis. The other thing is that there's been a lot of experience that when, in a sense, we reduce the choices a bit, people make better decisions. We learned that from Part D, where we reduced the number of choices after the program was implemented because we saw that people were making errors. And so the same thing should apply here. And then third, being honest about what the premium really is. We should be telling people, here's the premium, and it's the Medicare Part B premium, unless there's sort of a discount based on the supplements that go along with that. And we should be honest about what the actual net out-of-pocket cost is to the beneficiaries. And we don't do that. And that's a very simple fix. And then there's consumer decision aids. They've been put into place in Medicare over time. They're not very well accessed. They've been actually pretty successful in the healthcare marketplaces under the marketplaces put in place by the ACA. And so I think that we could do a better job of sort of supporting consumers with technology and with information support. Let me turn to Zuri's observations on vertical integration. And, he's absolutely right about where the market seems to be going. And there's a tension when we think about vertical integration. On one hand, you would think that health plans owning physician practices, hospitals, other kinds of services could potentially lead to better coordination of care, more continuity, and things like that. So that would be the plus side. The minus side is that you're creating market power that drives people towards higher drives the market towards higher prices and higher profits. And we don't know exactly how that sorts out, but there are opportunities, and the evidence that exists certainly doesn't make it clear that there's a huge efficiency gain from this. Although it's early days, and as Zuri said, we need to sort this out. One other aspect of vertical integration is that it creates new opportunities to end run some of the price regulations, like the medical loss ratios, because when you own a subsidiary, you can charge yourself a higher price and take your profits in a different form that's not regulated. So the physician practice can charge the health plan more money. That helps them on their medical loss ratio calculation, and it moves the profits into this other sphere. And so, to some extent, there are ways to address that through the regulation of transfer prices, but we don't do that. And so I think that's another thing to consider. I'll stop there. Oh, I will mention one other thing, which is the solvency. There are certainly some things that we can do based both on what Mark and Tricia observed to bring some money back into the trust fund from the Medicare Advantage program.
Thanks, Richard. So there's a very short question in the chat that I think relates to some follow-up that I wanted to have. There's been numerous comments about perhaps standardizing benefits in some fashion and trying to both make that easier for the consumer, but also trying to really get at how can we get plans to compete on a finite set of benefits rather than this, I guess what you're saying to some extent, or some idea of supplemental benefits that sometimes it's hard to quantify the actual value of those benefits. So there's a question that says, if my MA plan upcodes, doesn't that mean more money for extra benefits for me? And so, yeah, Mark.
I noticed this question and was kind of hoping that somebody would notice it. And so I'm really sorry to kind of butt in, but I want to try and say two things about this. The mechanical point and then a philosophical point. The mechanical point is I think, yeah, there's probably more revenue. There's probably some ability to provide extra benefits, but there's a few things to keep in mind, some of which I've already said. Remember, some of that goes directly to the plan. There's the value of the actual benefit, the stuff that I said in my initial comments. There was a issue that got implicated by Zuri and Richard, which the more you kind of own, physician practices and that type of thing, you can park revenue outside of the plan and fundamentally generate the revenue, but not feed it back in to the beneficiary. And also there's this mechanical question of like, okay, well, I got these extra benefits, how much, they're of value to me, but remember your premium's going up. So there's something of a like benefit versus what you're paying. And of course, if you're in fee for service, your premium's going up, but you're not getting any of those benefits. So, to the extent that sentence that Mark Pauly wrote is really about the people who are in managed care. But to me, the more important answer to that question is this. For me, the philosophical starting point for this was managed care plans came to Medicare and said, fee for service is a screwed up, redundant, dysfunctional system. And I can do a better job both on coordination, quality, and payment. And at this point, they have never delivered on probably a lot of that. But the last point, they cost more than fee for service. I would be much more happy about extra benefits for beneficiaries if it came from the efficiencies that the plan extracted, as opposed to the government just giving them more money. Of course they get extra benefits. It's a benefit expansion. They're just giving them money. And so that's kind of the way I think about it, sort of. But philosophically, it's the wrong place to be getting the money by gaming the system and just extracting the upcoding. I'm sorry I said all that, but that question I thought was right on.
Mark, that was great. I'm really glad you brought that up. And I think this comment by Mark Pauly also ties into David's last comment, which is how do we generate a bit more, or I believe maybe Richard mentioned this, how do we generate a bit more pay-fors out of MA for traditional Medicare? And the other side of this coding coin is the way we designed the benchmark system in the first place. So Mark had noted this at the beginning. I'm not sure if we have time to talk about it, but a short discussion of this might be that at the current law status quo, plans are bidding against an administratively set benchmark using traditional Medicare spending. Plan bids do not contribute to the setting of that benchmark. And so when you have competition, to the extent competition exists in a county, plans might lower their bids to try to beat each other out on maximizing benefits or rebates for beneficiaries. But to the extent they set their bids lower, that's not reflected in a lower benchmark to begin with. And so, as was done with when Richard was the ASPE at the end of the Obama administration, there was work on looking at what would happen if you reform the benchmark setting system to allow plan bids to play a role in determining the benchmark. I see Pete Welch here in the meeting. Pete and I were two of the folks at ASPE under Richard at that time working on this. And the basic sort of summary of what we found in this kind of analysis is that if you allow just average bids in a county to set the benchmark, rather than using traditional Medicare spending in a county to set the benchmark, you can generate quite a bit of savings for traditional Medicare from MA, exactly what you were referring to earlier. Our estimates written up a couple of years later were basically 11% savings if we assume no plan bid response to that, meaning when benchmarks are lower, do plans further lower their bids? If we assume they don't, if they just take a lower benchmark as given, that's an 11% savings to the traditional Medicare trust fund, if you will, or taxpayers. But if you further assume that plans will lower their bids in response to even a lower benchmark, which we find empirically to be true on the order of 50 cents lower bids for every $1 lowering of the benchmark, then that 11% savings grows to about 13%. And so this was estimated by the OMB at that time to be a roughly $77 billion saver over 10 years. And that's, of course, if you build in a couple of assumptions about how much we titrate this up and down in high-paying counties, high benchmark counties versus low benchmark counties. But setting aside that detail, I think the conceptual structure of using plan bids, which is a pricing mechanism, as a way to set prices in a competitive market is still fairly sound. And the pushback could be that in many MA markets, the competition is quite low. And that is true. In many counties in the US, there are very few MA plans competing against each other. So there, the competition may not work all that well. But the rejoinder to that is that it also happens to be the case that in those counties, overpayments are on the lower side. Turns out that relative overpayments are higher in counties where there's high traditional Medicare spending, and those are the counties with lots of plans coming in to offer options for seniors. And of course, they're coming in to offer options for seniors because of those relatively higher traditional Medicare baseline spending translated into benchmarks. So in those high benchmark counties, there is, relatively speaking, more competition that we can use from a legislative or policy standpoint to try to lower benchmarks, thus transferring some of these overpayments from MA into possibly making the traditional Medicare program a bit stronger and more of a robust competitor or public option to MA.
Thanks, Zuri. I think that a big question, and I think you're alluding to this, is how much can you reduce MA payments until the beneficiary starts to see a different experience in some way? And is that a question that we're able to answer today? Like, what would be the impact for a senior in MA if we moved to different models, whether it's through this benchmark approach or other mechanisms to try to at least narrow the gap between what we're spending on MA versus traditional, or try to bring them more in line with one another? What do we know about that? I don't know if anyone wants to tackle that.
I'm going to say, I don't think we know for sure. We heard a lot in 2010, as you might remember, where there was, the rhetoric was the payment reductions that were put in the ACA would mean seniors would lose highly valued benefits that they use and rely on. And, it didn't happen. I think we would certainly hear from the insurers that any reduction in payments would adversely affect enrollees. They're competing for these enrollees. So in some respects, they have a strong incentive to keep offering particularly these offering benefits for no additional premium beyond the Part B premium, because that's really what people see first. But we don't know. I mean, obviously, some of these changes could be phased in gradually. It would be interesting to see if they would be phased in gradually along with improvements in traditional Medicare, so that, when we're talking about standardizing benefits, we don't have a standard comparison between what's covered under A and B and Medicare Advantage and traditional Medicare. I want to go back to the idea that traditional Medicare does not have an out-of-pocket limit, but virtually every Medicare Advantage plan does, because it's required to do that. So there's a lot that could be done to offer more to beneficiaries, even as payment changes are being made to make the system more efficient and to lower costs. I just want to throw out a big question that I think people do need to start thinking about, which is, as we've crossed the 50% threshold and we see lots of competition, lots of marketing, one question for policymakers is, do they want to sustain the traditional Medicare program? Because it looks like it's on the way out. particularly in some markets where there's 60, 70, 80% enrollment. And that's a really significant question in terms of the future of the program and some of the payment ideas that Zuri was talking about. Because if we continue to base payment off of benchmarks established in traditional Medicare, and that program is going away, it's not going to work. And the broader question is, should there be a traditional Medicare program?
Thank you, Tricia. I just wanted to pick up on a couple of quick points, David, and maybe I'll transition to Mark. One is there have been 3 recent studies that have tried to answer this question about how much can we cut MA and what will happen to it. The basic policy motivation was it seems like there are a lot of folks thinking through how should we thoughtfully cut MA without disrupting beneficiary either access or benefits. And what these 3 recent papers show, recently summarized in an article in JAMA Health Forum, is essentially that if you have small cuts on the order of 2 to 3%, then that seems to not disrupt enrollment much. In fact, enrollment keeps growing. And that's studied off of the post-ACA cuts, starting in 2011 when benchmark increases were frozen. And thereafter, there are a bunch of counties in the US that got somewhat meaningful cuts. They weren't entirely substantial. Partly they were offset by the quality bonus program. But if you look at those cuts as really the only natural experiment we have for large-scale cuts in MA, enrollment did not slow down. And in fact, is sped through most of the federal projections. But there's sort of a medium bucket after that, where if you cut maybe on the order of 5 to 10%, I'm obviously guessing here, but something larger than the 2 to 3 to 5% range, either through benchmarks or scaling back the upcoding incentives through peeling back the squishy upcodable codes, then there comes a point when plans will have to pull back on their benefits or use other means such as selection or upcoding more aggressively to make up for that. And there you may see changes in beneficiary benefits or choices and access. And then of course, beyond that, there's a third bucket where if you really cut it by an amount larger, there are discussions about how overpayments are on the order of up to 20% if you count in both selection and upcoding effects. And those are hard to discern because methodologically, it's difficult to tell what the true subsidies to MA are, because it's difficult to tell what true risk is using claims data of billed diagnoses. But if you make cuts on that order of magnitude, then I think most people would agree that it would be disruptive in a way that we just haven't seen in our history of the program yet. So I think thinking it through in those 3 buckets sort of is helpful. And to Tricia's last point, I completely agree. As we go to a smaller and smaller portion of the beneficiary population in traditional Medicare, I think it does 2 main things. One is it weakens Medicare, a traditional Medicare, as a competitor or public option to MA. That makes it easier for MA plans to attract beneficiaries away from traditional Medicare. It makes it easier for MA plans to pass through less of the surplus to beneficiaries, thus keeping more of the profits. And secondly, CMS also loses an administrative ability to set benchmarks and prices in MA. And so if you lose that ability to administratively set payments for MA because TM has fizzled away, you are now only relying on competition between MA plans to set the benchmark and the prices. And in that kind of world, so-called MA for all type of scenario, competition would have to be robust. It would have to be regulated, but it will also have to be set up in a way where plan bids have got to play a role in setting the benchmark, since the benchmark no longer can use traditional Medicare.
Yeah, and what I was going to say, and I also want to get to the question that Tricia asked is, to the extent that we've heard these threats, if you do this, the benefits will be cut, plans will leave. We have not seen it. And 2010 was the big one, but there's also been small shocks to the system where the industry, immediately argues the Republic will fail, all of us will lose all of our plans. And there may be research opportunities. There was something recently on kind of the auditing function where they just said it was going to be the end of the, MA as we know it. It was a completely ridiculous claim. And now they're out advertising the increase in their extra benefits, even in the face of the implementation. So there may be small researchable opportunities where people can look at this. I believe you could take so much money out of the system to really have a negative impact. I don't believe we're close to that at the moment. But the other thing I wanted to just touch on with Tricia's point of like fee for service, no fee for service. this is a slightly different point, but one thing to keep in mind, I think people know this, but just to say it out loud, the existence of the fee for service has kept the prices that the managed care plans on MA pay much less than what they pay in the commercial sector. And a lot of this discussions kind of like, well, just make it about MA and just do competition and forget fee for service. To the extent that you say that there is no fee for service alternative, or say that when you go out of network, you only get your fee for service rates, the cost of this program is going to go up. And the rates that are being paid in the commercial sector are much higher than what Medicare is paying. And so I have this mixed thing of like the linkage to fee for service has some issues, but it also has the benefit of keeping the cost of the MA program lower than it otherwise would.
Can I jump in on the competition point? We have a paradox here. If you listen to Trish at the beginning, you'd say, oh, 40 plans, boy, must be a lot of competition. We're in this funny world where we have lots of choices and little competition. The market's highly concentrated, which is important because to some extent, the proposal that Zuri and I were involved in involves sort of pretty large scale competition, and it doesn't look like that's so likely. And so, in a sense, there are other ways probably of structuring your administrative system so it's not just a pure fee-for-service benchmark, but we have to wrestle with how we're going to set these prices. And I think it's risky to count on wide-scale competition right now. And so I think that, in a sense, Mark and Tricia's point, which is let's make traditional Medicare a viable competitor to the whole shooting match, if you will, that makes a lot of sense, even if you don't use the fee-for-service system as a pure benchmark.
Richard, if I could just ask a follow-up. So, in your comments, a lot of plans, actually few companies, at the same time, margins are big. And so theoretically, we should see entry into this space to see that competition, but we're not seeing it, it sounds like. And so what do we know about why that's the case?
Well, I mean, you do see entry. You have seen entry. It's, but, in a sense, in economics, we talk about something called a competitive fringe. And I think that's kind of what you're seeing, that the big five plans, United and so on, Aetna and so on, are all have a lot of market power, and as you say, have very substantial margins. And it's a little hard to sort out what the profits are, but to Mark's point, when you look at sort of some of the pure plays like Humana, which is largely an MA thing, you see a reflection of the weak competition, which is significant evidence of rents, which aligns with both Zuri and Mark's comments, which is there's some room here to achieve some savings without hurting either the quality or access.
Great. Well, I'm looking at the clock. I see we're starting to run short on time, and so I did want to transition to a wrap-up question for you all. And of course, the wrap-up question is never an easy one. So if we look at the next 2 years and put yourself in the position of policymakers who are wrestling with some of these budgetary issues that I think all of you have spoke to in some fashion, and you look at this rapid growth of Medicare Advantage, what's the most important thing the federal government can do right now over the next couple of years to lay the groundwork for future reform that sets us on a better path than where we are today? And so who wants to tackle that easy question first?
I'll get it over with. I think we could think about what the regulators can do and what Congress could do. And Congress has sort of talked about, Mark, you used the term right-sizing payment at one point. but there's been real resistance to that, whether or not, that's certainly something federal policymakers can consider. It's in their wheelhouse. There are also things that regulators can do. But there are also other very tangible things that can be done that would make the marketplace more transparent, which I think could be very, very important. We've talked a lot about the attraction of extra benefits. So, for example, what are people actually using and getting for all the advertising that we are seeing? We have no idea. Denials, I think it'd be very helpful for people to know about denials across plans. So I do think, and network accuracy and some kind of monitoring across plans. There's a lot of work that could be done to improve what policymakers can know, researchers can know, and beneficiaries can know in understanding how well the system is working and how to make choices, which is kind of what this thing is all about. And more information too about payment in real time would be very helpful as well. But there are other things that can be done to simplify the market. Richard talked about people can't deal with choice and the paralysis of choice. There once was a time when there was a requirement for meaningful differences, which allowed for fewer choices. I think in Philadelphia, one company has 12 plans. There is more that can be done to help the consumer, and more that can be done to get information to help all of us understand how this program is evolving and how it's affecting people.
All right. Richard, do you want to tackle this one next in
Sure.
30 seconds or less?
Yeah, sure. Mine would be, well, I agree with everything that Trish said. So, but my addition would be to really do a variety of things to promote competition. If you want to bet on competition, do everything you can to make it real. So one thing would be get away from using the county as a market definition. There are lots of ways to reorganize markets so you can actually get enough plans in to compete. A second thing would be make it harder for plans with a lot of market power to do things like vertically integrate and game the regulatory system. And then I guess the third thing is kind of be honest about the information, make people understand what they're really paying and getting. And then finally, make traditional Medicare a viable alternative.
Zuri, you want to go next?
Sure. Thanks, David. I would say make the traditional Medicare program stronger, as Richard and Tricia have noted. I think currently the system is performing the way that it is set up. The substantial subsidies to MA make it so that it's so much more attractive relative to traditional Medicare. And there's plenty of explanations in that for why beneficiaries have voted with their feet to move to MA. But there are many ways in which we can make traditional Medicare a more viable option that disciplines the MA market. And since we know that more Black beneficiaries and disadvantaged beneficiaries now increasingly through duals and special needs plans are enrolling in the MA program, it's even more important that there's a viable competitor to discipline and serve as a counterweight to this MA program, which is caring for increasingly disadvantaged beneficiaries. And so obviously there are many ways to do this. We've talked about some of this, but I think having that viable alternative and retaining the administrative ability of CMS to set benchmarks and payment rates in a way that makes both programs viable rather than losing one and just having the other. That would be my answer to your question.
All right, Mark, you get to back clean up, but there's a pitch clock. So
okay, and so I'm going to define this very narrowly in a very short term. It's like one thing in the next year or so. Recapture all of the upcoding instead of don't leave that $20 billion overpayment out there. Recapture it.
All right. Well, I want to thank all four of you for this excellent discussion today. I know it's a complicated issues with lots of elements to it. I know we didn't get to everything that probably we could have today, but it was a really great conversation to have with you all, and we really appreciate it. I do want to mention to folks in the audience that our next virtual seminar will be on December 1st, and the topic there is what happened to the nursing workforce. And so please do visit the LDI website, and you can register to attend our upcoming event. So again, thank you to the panelists, and thank you to our audience, and wish you all a happy weekend.